Question would go to my co-chair, not just because she is co-chair, but she is among the, I would say, most authoritative leaders in digital health in this country. She is the former CIO of Max, and under her leadership, India got the first paperless hospital, HL7 level hospital. And I think she has seen all weathers in digital adoption. So my question, Nina, to you is technology for the patients, or are patients being used for technology?
Actually, it's a very interesting question. And actually, I sat down yesterday to prepare for it. So I'm not really going to spend too much of time on technology for patients, because I think we have a lot of people here who will talk about it and may have spoken about it. And, name a technology and we're trying it for patients now, which could be even 3D printing, could be prosthetic limbs, or tomorrow, I hope things like we start printing kidneys and heart also. Maybe that'll happen in India also. It's still in research. So there's a lot of technology that's being tried for patients. But let's see the other side of it, which is, I think, more interesting and little unique. I don't know how he got this idea of saying patience for technology. So I think the moderator did speak on something of patients and technology. Are we trying to build technology around patients or patients around technology? But let me try and say something different. See, I think there is a need to use patients around technology also. So I'm going to try and bring totally a different perspective. And why and how? When we start working on using technology for patients, one of the problems that comes is, what is patient's feedback? How does the patient take how it's doing? So if your patients also talk about technology, whether the technology is, suiting them, it's good, bad, ugly, or useful, I think it's very important. There was a time actually we spoke about even crowdsourcing of data. We've got somebody from NHS, we've got electronic health records person from AT also coming in here. One of the problems I think which we need to all as India evolve is that we need to get clean data from hospitals of patients' diagnosis, so that we are able to take better clinical decisions for tomorrow and come up with new medicines, etc., also for tomorrow. And that's possible only if we are able to use the best of AI algorithms which India can create on clean data and the right data. How do we get that clean data? It is actually the patients who can provide it. It's the hospital who can provide it. But as per the data protection law, a hospital has no control on my data. So I have to give authority to doctors or the patients to provide my data to that huge, beautiful EHR repository that our government of India is creating. And if that gets created, I think we are going to be sitting on top of, something which is going to be just wonderful. No other country in this world has that level of data that we will have if patients also help the technology. That was my one small thought that I thought I'll bring it. But I think as we go further, I'll talk more, but I thought I'll start with this. Because in today's world of artificial intelligence, we've got Bhashni, CEO of Bhashni sitting here, and everybody, every day, the newspapers are full of AI. AI is just AI without data. It doesn't make sense. So it's all of us as patients who need to provide the data to make that happen. And we'll talk more about how the other part happens.
Yeah, I'll ask the next one, then I'll pass it on to you. So Himanshu, how large is the presentation? Because you have the largest digital health program of this world. Yeah. So how big is the presentation? How many minutes would that be? How much you want to give? 10 minutes? Okay, so we'll let Himanshu talk about the National Digital Health Mission, which is we should be very proud of. Now, India is the biggest implementer for digital health, and I have known Himanshu for a long time. One of the doers who silently does things. We have 760 million Aadhaar IDs rolled out, 522 million health records linked. Just imagine the scale at which they are operating. And I thank Himanshu for coming in. Himanshu, it's over to you. You can do your presentation before we talk again.
Good evening, everyone. I have been given 10 minutes to walk you through the digital health mission. I'll try my best to give you a fast overview. of what government is trying to do under digital health mission. Now, the first thing I want to start with this to set a premise or a preamble for everyone here. With a show of hands, if you can give me a count, how many of us are using UPI? Right? Everybody's using. Now, what UPI has done is that it has basically made our lives, I would say, convenient. As basic as that. There is no hassle for smaller denomination. There is no hassle for uh, forgetting your wallet and other things. So, because of this, and we as a citizens adopting the entire UPI framework, so I would say joyfully, India is right now leader in digital payments. So we are clocking daily transactions more than Visa and Mastercard combined. In last year, we have clocked 49% of world's digital payments. So, and mind you, UPI has just reached the user base of 250 million. We have not even touched 1/4 of our population in that sense, but still we are clocking such huge numbers, right? This was possible because of Jam Trinity, as it is called, that all of you had a bank account, you were verifiable through Aadhaar, and of course, data. On top of this, the NPCI built a protocol called UPI. UPI is actually a protocol and which gave us the interoperable payments ecosystem. Now, the beauty of this interoperable payment ecosystem is that somebody might be using PhonePe, somebody might be using Google Pay, somebody might be using Paytm, Cred, Kiwi, whatever you want to call it. New UPI apps are coming on a daily basis, and we are using as per our choice, our convenience. No government is thrusting a single application onto you. You're choosing as per your convenience. But when it comes to healthcare, this is the problem which we face. We have to take loads of file with us. We have to stand in queues, the entire, I would say, hospitals, barring a few islands of excellence here. But largely, this is the picture which we get in our healthcare ecosystem. There are no trusted actors, no verifiability. You would see on a daily basis, there are some bogus doctors who were doing some angioplasty and poor patients died in this country. This is happening on a daily basis because as a citizen, we do not have the power to verify who is the doctor who is treating us, right? These are some of the issues which we face. And eventually what we are having right now is an inefficient, low productivity healthcare. Even after this, we are able to attract, I would say, global medical tourism because of our, I would say, very sustainable cost. But still, the idea to raise these two, I would say, paradigm is that there is a huge potential in India which is ready to be unlocked. How and where we want to go. Can we have a scenario where all the stakeholders are trusted? By stakeholder, I mean, when you go to a doctor, do you know whether the person is a doctor or not? When you go to a facility, do you know this facility has been actually verified by some government regulator entity which is meant to do that job? Your health records, you can access digitally. And lastly, they can also be exchanged. You don't have to carry your health record. Some of you might be, let's say, traveling from Bangalore, Bombay, but you do not have a ready file with you, right? Can those health records be in your phone? Readily accessible, because as you know, the NCD burden in India is also rising. So we have those disease with us, and a large section of our population is also moving to NCD disease. So this becomes very important to have health records at our disposal all periods of time. Given that, I think I would just latch on to what Dr. Nina said about data. We need that data. Only that will be able to go towards a low cost and high trust healthcare ecosystem. Now, what we are doing is the Honorable Prime Minister of India launched Ayushman Bharat Digital Mission in September 2021. What it does is following things. I'm not going to repeat what is written, but this is, I would say, these are the most important 5-6 lines which says that you have to, the idea is to have universal health coverage, open standards, interoperable, standardization. Only after standardization we'll have the scenario what I think Dr. Nina just mentioned about AI and other things, and security, confidentiality, and privacy, because we live in an era of digital, and privacy and security has to be paramount. And that's where I think I want to touch upon the theme of this session is the citizens are at the core of this entire mission. Ayushman Bharat Digital Mission has fundamentally transformed the way in which healthcare has been delivered. the entire power has been given to citizens, and I'll walk you through how we are achieving that. Similar to UPI, what we are trying to do is these, I would say, 6 things which government is doing. It is creating single source of truth or registries. One is for citizens, one is for healthcare professionals, one is for health facilities, and on top of it, there are certain gateways, which I don't want to get into right now. But these 3 things are also very important. What it does is that it gives us trusted actors as well as verifiability. How it does is, this is what I want to also show you. This is a public website which NHA has made. This is Know Your Doctor, Know Your Facility. We are issuing healthcare professional ID to each and every doctor, both traditional as well as modern medicine, includes allied healthcare professionals, nurses. Name any healthcare provider or professional which we have, they have an HPR ID, or they will get an HPR ID going forward. Similarly, all the healthcare facilities are also given HFR ID. And this is a public dashboard. So next time you go to a doctor, ask the doctor whether you have an HPR, put it in this website, check their details, and you will get to know this doctor is verified. Now, this is something which we are not verifying. This is NMC which is verifying this, that the National Medical Commission, the Nursing Council, the Nursing Commission, the Dental Commission, all these commissions whose job as a statutory bodies is to verify, they are doing this verification thing, so that eventually we have this database. So NMC had a National Medical Register. On top of this, we are building these services for citizens. So this is one way we are trying to put citizen at the center, that citizen has the power that, okay, this is how I verify a doctor. Next time you walk into a clinic, ask the doctor for their HPR ID. If they have not registered, ask them. Similar to what I think we have been doing, asking the merchants, do you have the QR code? If you have the QR code, show it, we'll transact it through it. Now, this is something which I want to highlight here, that there are certain, I would say, myths regarding ABDM. So this is how things currently work. You walk, there are certain things which I've written, RCH, e-hospital, e-Sanjeevani, but you can replace it with even the private hospital, put Apollo, Max, Fortis also. They're all siloed system right now. If you walk into Apollo, your records will stay in Apollo. They will not be transferred to Max or be transferred to Fortis. You have to physically carry it with you. The systems don't talk to each other. Many of the people think that, okay, this is what ABDM will do, that they will create a centralized repository. But I think we do not want to create a centralized repository. This will be a single source of failure for this country. And again, health records are something which are dynamic in nature. This is not a one-time exercise like Aadhaar, where you put in the biometric details in one single, I would say, secure location, which is more of a stack thing. But this is a flowy thing. Every year, India generates around 600 crore health records. So by the end of 5 years, I'll have 3,000 crore health records. I can't keep all the records in a, I would say, central repository. So again, this is not what ABDM is doing. What ABDM is doing is that, again, putting the citizen at the center. You go to any facility, you just give them your ABHA, your records will be linked. Now, how that transaction will happen is something like this. Imagine ABDM as a master switchboard, and all the rest of the entities, be it your private hospital, government, programs, frontline workers, laboratory, health application, anything, all as the spokes, right? So the master switchboard basically connects all the entities with each other, but it does not store anything. So think about it. You can't light a bulb at your master switchboard, right? Bulb will be only lit when it goes to a holder side. Similarly, if you want to access your health records, you have to go to those programs. From there, you get the access, right? This is what we are enabling. Now, benefits, again, I think we will talk about this, but this is something which I want to put out there, that citizen, patient empowerment, better control over health, time and cost saving, and personalized care. Because until unless you don't have a longitudinal health record, you'll not be able to give a personalized care from the doctor side. Similarly, for providers, better clinical decision making, which I think Dr. Neena also touched upon. Easy compliance to laws is something which I want to emphasize, because medical profession is also highly regulated, and there are a lot of burden of compliances to all the healthcare professionals in this country. With digital, we want to ease that thing as well. How you initiate your journey, this is something which I want to highlight again. ABHA, Ayushman Bharat Health Account, is something which, as a citizen, we all should have with us. What it will give you, it will give a unique identifier to you. Privacy by design, as I told you about. Longitudinal health history is something will be created because you will give your Aadhaar to each and every provider. This is how your health records, let's say you go to any programs, this is how it will be created. But better than this, I'll show you my longitudinal health history. This is my longitudinal health history. I have taken a COVID certificate. I have taken a primary healthcare center in Korlim. I visited that. Then I visited LHMC, AIMS, CHC Fulwari Sharif in Bihar, referral hospital Sakra again in Muzaffarpur. So this is a longitudinal history I have in my phone right now. These are the facilities which I've enabled, and this is something which I have. Benefits, again, I don't want to spend much time on it, but this is known that medical errors would be prevented. Early detection of disease is something which will be highlighted.
Can you ask how many are using this and what are the benefits of them? I mean, I think all of us know, but I think you're not using it. I think that is something they should all. So, one of my requests to you is, first, let me ask, how many of you are using Aadhaar IDs? Just this. Do you really know the benefits of using Aadhaar ID? See, this is the biggest program, and it's not something that we should just download or create and keep it. And I would want Himanshu to dwell on this, because not only we should use it, we should ask others to do it also. There was a vision behind it, and there is a reason. And I think this is what Himanshu should share with us, like what are the benefits people will have using it.
Yeah, so this is something I'll again show you with my history. This is one of the services which we have built on ABDM. This is again right now in the government hospitals, but also can be leveraged by private hospital. Again, this is their choice. If they want to use it, they are free to use it. But what we have done is, this is a scan and share thing. What it does is that if you go to a public hospital, if you have been there, there are long queues, right? You have to wait at least an hour or 2 hours. If you have been to AIMS for OPD, these will be the challenges. And once you reach the, let's say, counter, you will be struggling to say your demographic details. They might enter it wrongly, and so on and so forth. So this is very basic thing which we have done, is that using your Aadhaar, which is a KYC thing, we are saying that, okay, this is a name, age, gender, all are verified. So the hospital need not ask you again these details. They can simply capture your details once you scan the QR code. Now, how do they capture it? So again, these are my screenshots. On the left-hand side, you'll see this is my Aadhaar details, where I have my name, age, gender, address also, and I have to simply scan the QR code and get token. The token is received by me. I don't have to stand in queue. It's simply similar to banking ecosystem, where you take a number. Once your number comes in, you go to the counter and you take the services. Similar to that. The second is the most important thing, the health record linking. This is my record from AIMS New Delhi. Diagnostic report, machine readable. This is again in XML format, can be used for multiple other things. I think what Dr. Tina also mentioned. So this is live, this is possible, and this is being done. Third is the consent framework, where you give your consent. This is putting power of your health record into your hands. Only the records will be transferred only when you give an express consent. This is a consent which I have given to the district hospital in Patna when I was visiting for some official purposes, but then I was trying this. And only when I gave the consent, the records were transferred, or records were actually not transferred. They could see it for a brief period of time when I said that, okay, they can only view it for 5 hours. They can only view it for 1 day. So this is again, consent power being given to citizens. You can define those terms. And lastly, something is scan and pay, which we have launched in all the AIMS, where again, you have got your registration, but you still have to stand in queue once you take the diagnostic services. You have to pay for lab services, 20 rupees, 30 rupees, still you have to stand in queues for 20, 30 minutes. So this is something which we have done. Now you will say that, what about my family? Not everyone is smartphone savvy or other things, right? So this again, idea is to have a CoWIN-like system, where you had one mobile phone and all your members could be registered on it. So similarly, you can have one mobile number, but you can link 6 Aadhaar numbers against it. Your family records can be managed by one individual. Now, I would like to call that individual as a chief technology officer of your family, who helps the family to navigate multiple digital paradigm. This person can be a 17-year-old also. who knows how to navigate the system and can help their parents, grandparents who may not want to navigate the digital health. Now, how do you participate in this digital mission? As I think Dr. Gupta also mentioned, this is a choice which we have given you. You have created your ABHA, but you don't know how to use that ABHA. The way to use that ABHA is to use certain applications. We call them personal health record application or PHR application. The choice is again given to you. There are right now 14 PHR apps which are integrating with us, and more are also in pipeline. You can try all of them. You can try 2 of them, 1 of them, whatever is again your choice. And you can play with that, which is giving you the best services as a citizen. So this is something which we have given to you. What Dr. Gupta also mentioned, that the advantages, you can carry your health record in your phone at all times. So if you are visiting any city, your records are with you. You can share with any other doctor. If you have any complication, share it. If you want to get a prescription, which are, let's say, Schedule X drugs, which need a prescription, this is readily available in your phone. So those things are possible as you go and as you move forward. So these are, I would say, we have just started to scratch the surface. The benefits are immense. We have been talking to multiple countries, and they have all shown immense interest in this digital framework because this is interoperable, and this is something which is readily, I would say, able to export also to the other countries. Here, I want to emphasize that these are the certain programs which have integrated with ABDM. That means you can go to these touch points and get your services in an ABDM enabled manner. But my request here to all of you is that next time you visit any hospital, ask for taking your ABHA. They should take ABHA so that when they generate the health record, they can link it and you can have access. Why should you have to go back to a hospital to collect your diagnostic report after 24 hours, 36 hours? Shouldn't it come to your phone directly, right? Usually this what happens in all the, let's say, large hospitals, that okay, you have given your sample, come after 3 hours, 4 hours, 24 hours, and then you get your report. But this can easily be given in your PHR application. You don't have to visit. And again, this is a data which will be machine readable and would have larger benefits of clinical decision support system and so whatnot. So again, the request is ask for ABDM enabled services in the hospital. This will only happen when the citizen asks for services. And this is where I think patients for technology comes into picture, where patient have to demand technology from the hospital. Hospital for long have not been, or I would say have not given this services in that outlook where the patients are asking for them because of, I would say, power dynamics and other things. But I think now we are entering into a paradigm where we are giving power to the citizens. Now citizens have to demand it from the hospital that my records will only be shared if I give the consent. My record should be given to me in a digital format. You should capture ABHA. You should give me all these services. You should give me all these features. So this is a request to all of you, and I would want to leave you with this last slide, which basically sums up that what you have to do is that create your ABHA, use a PHR app. If you want to put your records into a digital locker, create a digital locker. We have also enabled DG locker for this purposes, and start transacting digitally your health records. And eventually, I would say we would become a digital health citizen in that larger sense. So this was it. Thank you for time. I think I overshot. I'll be happy to take any questions as well.
So I'm going to start with something before you come up with a question. Sorry, we'll give you time for questions. So wonderful initiative. I think, as Himanshu is saying, we all need to start using it. But let me tell you something which maybe I'll add something to what he said. You know, when I started implementing EHR, I was given a couple of tasks at that time. And I just share that part of journey also. You know, when we go to one hospital, it says, okay, get ABCD test done. Okay, I go to another hospital. Another doctor sees it and then maybe asks for another same set of tests done again. So one of the mandate which was given to me when I implemented EHR, which was more than now 12 years back, 12, 13 years back in fact, was can we avoid these duplicate tests? Because a test is valid for some time, of course, unless of course you're taking some medication, you need to get the t-test done, but then otherwise tests are valid for some time. So can we avoid these duplicate tests for the patients and reduce the burden there? Second, all of us have some kind of allergies or reaction to some kind of medicines. Now, he talked about that my data can be carried in a phone. But when I move with the data, can that information about me, or what allergies I have, or what reactions I have, or what medications I'm currently taking? So suppose I'm taking an antibiotic right now, but doctors should not, I mean, there are more doctors sitting here, they know more than me. Should I be prescribed another antibiotic? Should they look for whether I'm allergic to a particular medicine? When did I last take antibiotic that I should not take a new antibiotic, etc., etc. So I think those are some outputs also which will come out from the system he that spoke about, which I think is going to be the next part. But I think there was a question, so I'll leave that to the question first. Okay. So Rajendra is suggesting that we take the questions at the end, if that works for you.
Yeah, so we'll take the questions at the end once everyone has spoken. Yeah.
Right. Now, let me tell you something about a story about EHR, my personal experience, and then I'm going to move to actually CEO of Bhashni. And so, when we started implementing EHR, one of the problems that we faced was, and this came also from NHS, and still I think it's a very valid problem, is that when the doctor starts speaking to patient, either he speaks to patient and he has a eye contact, or sorry, if you lost me. And the second could be that if he starts entering data about me in the computer, there are times he loses the eye contact. So what do we do to ensure that the doctor maintains that eye contact and also enters the data in the electronic health records or the systems that he has, so that my electronic form of data comes? So that was one form that problem, it came when we went to the OPD to implement electronic health records. Let me talk about more problems. And I'm sure the doctors here face that problem. So when the doctors went on a round to the IPDs, so typically, I mean, we had senior doctors visiting the IPD, and they were accompanied by junior doctors and also the nurses and the staff with them. So doctor would give instructions. Now those instructions would contain the medication, what food he needs to take, he or she needs to take, or any other, whatever emergency instruction. The doctor does not have that luxury of so much of time to type it out, right? And there were times that those set of instructions which the doctor was giving were verbal and of course were getting lost. So we tried something like recording those also, etc., etc. But it would take time. The third problem that came was when the patient was to be discharged. His report had to be created after the doctor said, look, the patient can be discharged. The report had to be created, but doctor typically dictates or talks about it, right? How do we ensure that that information really goes to electronic health records and we improve the discharge time, which is there? So once he says discharge, the discharge summary is prepared, and it goes to insurance. So it takes a lot of time. So how can we bring in technology to enable a faster process? And I'm going to put the question to actually CEO of Bhashini, who's going to solve all our problems like this. So there is actually government working on all these issues to solve these problems.
Yeah, I think, some of the problems and some of the challenges which you talked about are on our radar for solving it. So let me start by, giving a short introduction on what Bhashini is trying to do, and then I'll take you to the applications of it. We are currently solving 5 basic problems. That is automatic speech recognition by computer. So computer should be able to recognize what I speak, and that too in the mother tongue. We are translating one language to other. So if you have text coded in one language, it will get translated to other. And then we do that in 36 languages today. And then the computer should be able to speak out what is coded in the system. So that is text to speech. And that is, again, we do on 22 languages today. And then we have a lot of printed material which needs to be recognized into machine readable form. So that is optical character recognition. We are doing it for printed, and we are attempting to do it for handwritten as well as on scenic text. And then there is a lot of vocabulary which is there in our multiple languages, which is not digital till now. And we are attempting to make it digital by creating glossaries of it. So these are the 5 basic problems which we are trying to solve. And today we have AI models for that. We have created service IDs for that, and that is being rendered on the system. And we have just touched 2 billion inferences or 2 billion translation requests on our platform since we were launched about 6 to 8 months back. So, and that among that, about 1 billion is only translations. Rest are other services like automatic speech recognition and other things. So, a progress and a system which is well done, which is approximately we do about 1 crore translation requests a day and 150 translation requests a month. So that is the scale of the platform on which we are looking at. Now, when we went on to the health field or the medical field, we had, possible interventions at all level of health, means preventive, screening, diagnosis, treatment, after treatment care, and then care delivery, etc. The first piece which came to our hand was disseminating information. So the app which we launched today are, the other websites, etc., translated. Japaigo, there is Audiopedia, which gives information about the various, challenges which people face. So it's dissemination of information into multiple languages. That was the first challenge which we started solving. Then, for example, the Jan Aushadhi website is now in 22 languages. So you can know which, in your own language, where the medicine is available at a cheapest cost or a generic medicine is available. The three problems which she talked about, first is about patient-doctor interaction and transcripting it into a database which will actually take the things forward. So we have experimented with that in some form or the other. In Rajasthan, what we had done was that the data, it means it's not exactly the same, but Rajasthan, the challenge was that nurses were not entering the data with respect to the birth of the child in the system because they were not digitally savvy. So we created a voice-based form filling system by which the nurses started entering the data. So what used to happen that after a month's time, a digitally savvy nurse would come and she will enter the data for all the nurses across the spectrum. So that actually has got rolled out across Rajasthan, and it's one of the important systems there. We are about to launch a innovation challenge, which is on 15, most probably subject to the various activities, where we are exactly tackling this problem and inviting people to create solutions around it, which is that doctor and patient would continue to speak and have the interaction. And through the automatic speech recognition, the system will capture what doctor and patient are speaking, and the AI engine would try to facilitate that entry into the EHR. And we would like to actually, most of the data when we're looking at EHR, people fill in some, wherever there is a star, it gets filled. And wherever there is no star, it does not get filled. So the idea would be to fill all the fields which are there, because when you're looking at AI-ready data, the first thing is that it should be a comprehensive granular data, otherwise it will not have sense. So this, we have done some initial experiment, and we are hopeful that we would be able to roll out this product in next 3 to 4 months with the help of startups who would work with us in this. And there are heavy awards for that, and there is a deployment mechanism for that. As regards the discharge summary, which is there, so that also has been implemented, and we would perhaps take it to the next step as we go by. NIC has implemented that in their e-hospital system. But any of the other hospitals which want to implement it, we are happy to work with them, because the discharge summary, can be dictated by doctor and it gets automatically transcribed into the system. There are a few challenges which everybody will perhaps speak about, and we are also working about it. There are challenges of dialects. There are challenges of the issues which are related to internet and technology, whether it is, because we are actually inferencing on the cloud, there could be challenges around it. So on the dialects piece of it, we are actively currently working with all the state governments to capture all the dialects, right? So just before I joined in here, I was with Additional Chief Secretary of Odisha, and just to give you one state example, what we are trying to do there is run a 1 month long program where we are encouraging all the citizens and the colleges to give, do a Bhashadan to capture the dialects across the things. This would also be added. There will be also another track to it, which is basically asking each one of them to talk about the respective local cultures and about the district, about the places which are there, etc., so that the data gets enriched with respect to the vocabulary which is there. And then we are also looking at celebrating the important personas in that state from, with respect to language and with respect to speech, so that we are in a position to again capture the things here. So similar arrangements we are going to do with all the states which are there to enrich the digital vocabulary of the language, of each of the language. Today, 70% of or 80% of the internet or digital vocabulary is captured by a few languages, right? And Indian languages are not among them. So our challenge of creating AI models, translation, automatic speech recognition, all of that starts from there, that there is not enough digital data. And we did one of the exercise when we started building the models in an initial phase where we created digital data. What it eventually means is that we hired about 200 translators who were on the field with the picture of something on their mobile, and they were going to people and asking them to write or speak or do something about it, about the picture, so that we can get digital data. And when we created those digital data, we were in a position to create those initial level of models which are there. But as you know, language is about 10,000-year-old subject. It evolved over 10,000 years, and it's not going to be an expressive solution which we can just build it up. So it's going to be an evolving exercise. And of course, we are fortunate today, we reached 2 billion today because we actively worked with the customer, took their problems, solved them, and went back to make the things, trained the model again and again. And hence, they found the level of accuracy to be sufficient enough so that they can use it for a general purpose. Today, for last about a month, we were actually in the parliament, translating what was happening in Parliament Union Conference into multiple foreign languages as well. Of course, we were interfacing with the existing model to get the translation on the foreign languages. But those all experiments have been successful and appreciated. In fact, it went across through various discussions around. So we will reach there. The idea is that we are in the journey, and the journey has to be taken up together.
So I'll give you, the example of how Bhashni is making technology for patients. So within the IPU app, one of the things that we wanted to do was not restricted to English and Hindi. So we, talked to Bhashni, we had an MOU, and in 3 months' time, this app is now in all the languages Bhashni offers. So this is the first, proof of the fact that there is a solution from the government that makes it more accessible, in terms of at least information accessibility, we are able to do through the Patients Union app. And I would encourage you all to use it in different languages, because the more data you use, the more robust Bhashni platform would be, right, Amitabh?
Yes.
Sounds really wonderful. I didn't know that we were using crowdsourcing as a concept to even improve Bhashini, I would say, right? Which is what I just said. So I think it's actually people who make any product a success, whether it is a healthcare product or Bhashini or electronic health records. So I think it just goes back to what I've mentioned about crowdsourcing of data to make, whether you give it in Odia language, what is the English translation for it, or you talk about the image, or tomorrow, maybe there's a possibility that there is a doctor who actually speaks about an X-ray image and says, look, this X-ray image is fine, but this X-ray image may have ABCD as a problem. So what are we trying to do by doing that? Is that technology is really learning from you the rules of the game, because technology does not understand what is right and what is wrong. So at the end of it, you need to teach technology, and it's the doctors who can actually tell that if this is the X-ray and this is the MRI, or these are the medicines the person is taking, and this is the other diagnostics, this could be the health condition. But that those rules of the game have to be written by actually the doctors. But somewhere we need to, as technologists, come up with a framework where we can actually write those or convert the rules that you have in your mind to a rules that a computer can understand, which is actually complete game of ML and AI. There's a I don't know whether you people have heard about uh, a product which has been launched by a Bangalore set of ladies, and I think their name has been spoken about in all startups, sessions where we talk about females creating, healthcare startups. So this lady, what she did was she actually created a product for a cheap product, in fact, for scanning of breast cancer. So what they've done is they've actually used a concept of, they've actually created and taken a lot of images. They started off with images which had the breast cancer, and they stored those images. And now a lady needs to go via thermal scanning, which actually tells you, and that image is actually compared with the images which are stored of the cases where there is breast cancer. It tells you that 99%, 98% with accuracy that there is a breast cancer case. And if it's then confirmed by doctors like you, then it again goes back to database saying that, look, this 98% case that we were talking about actually is a 100% case in the case of breast cancer. That's how we are actually building the data to actually make technology work, right? So and that particular case startup actually has reduced the breast cancer screening cost to almost 1/10 of typically what's there in normal hospitals. I'm not saying specialized hospitals, but normal hospitals, if they charge 1,000 rupees, the cost has come down to 100 rupees. Similarly, I think there is a need for a lot of innovations. And I was just speaking to Jay from METI, my previous organization. I think I was really happy that I think there's a lot of work happening on new innovative products, and a lot of products which are now being planned. I think there was an announcement by, and there was actually speech from our Honorable Prime Minister where he spoke about an MRI which is created by India, which is by METI again, which is going to be actually put up at AIMS itself. But there's a lot of other work which is happening. So maybe Jay, you can talk about what are the different initiatives Ministry of Electronics is doing to create different products which are required for making healthcare a little simpler and, of course, also handleable, economical, I should say.
Thank you, ma'am. So I work with the R&D in electronics, wherein we work on medical electronics and health informatics vertical. The persistent challenge for us is to make healthcare affordable and accessible to all, especially to the underserved, unserved population of our country. So if you look at the healthcare scenario, especially these medical devices, largely we are dependent on the foreign countries. We depend on the foreign technologies. Our economic goals have been met up to some extent with the initiatives such as Digital India, Atmanirbhar Bharat, a lot of schemes like PLI and PREP. Those schemes are able to attract manufacturers, local manufacturing particularly. And therefore, we are up to some extent in low value medical devices. Over 60% of the medical devices are being manufactured in the country. Still, in the high-end medical devices such as CT, MR, we are largely dependent on imported technology. So the challenge is affordability and accessibility. And from our side, from the side of ministry, we look at how do we democratize the technology. Typically, if you look at any business model, any company who has got some idea, convert it into a product and then create a value out of it. And then they try to take over as much as possible the market share. So I would like to mention one book, Platform Machine Crowd. So from the idea, product and core, can we transform into a machine, platform and crowd? So I build a smart machine which serves as a platform, allow innovators to make experiment, develop innovative solution, and with the crowd, with the help of crowd, I allow all sort of stakeholders to come on a common platform, create solutions which can go to citizens directly. So with this philosophy, indeed, the same philosophy has been adopted in various core platforms of METI, be it Aadhaar, DigiLocker, UPI. Indeed, ABDM is also aligned with the same philosophy. ABDM and Bhashini, these are the sectoral platforms. When I say sectoral platforms, these are sector specific digital infrastructure which allows all sort of stakeholders to come co-create and provide unique solutions to the citizens. So the same philosophy we try to implement in medical devices. And as Madam said, I would also like to take this example of MRI. MRI is one of the most complex technology, which includes expertise, extreme level of expertise of cryogenics, physics, uh, computer science, mechanical engineering, and then obviously the medicine side also. So what we had done is, instead of creating or using proprietary technologies, what we did is we tried to democratize. We broke down entire MRI into basic building blocks, which can be reused, which are not vendor dependent, which are actually vendor neutral. And with this approach, we could develop the entire system from scratch. And so far, what we have done is, with bought out magnet, we could successfully complete the animal trials. Very soon, we would be putting the machine at AIMS for conducting human trials. So my point is, if I open my technology stack, and if I allow researchers, innovators, startups, MSMEs to come co-create, join hands with the government, and deliver solutions to the public, we can actually enable the entire ecosystem. While working in these technologies, one particular statement comes from a big person. Is I still recall that he says that we should synergize to energize the entire ecosystem. So this is what we do in medical electronics and health informatics vertical. In addition to MR, we could also successfully develop ultrasound transducers, ultrasound machine. Every year, we almost import thousands of ultrasound machines. We also, there are a lot of, AI-enabled solutions we could develop, which are being developed and tested at various hospitals. On medical device front, we could successfully develop and deploy blood irradiator, which is largely used in leukemia treatment. We had that linear accelerator. We also developed the breast screening device, sort of a jacket with the help of thermal screening. So, a woman can be scanned with the help of thermal imaging. So these devices, what we developed, we actually onboarded industry also, who could take the technology, proliferate in the market, and serve our citizens. So with this brief, I would like to conclude here. And thank you, ma'am.
Thank you so much. I love this quote, synergize to energize. I think it's a wonderful thing. I think we need to all work together. Now, before I move to my last panelist, I thought I'll tell you something of what I'm trying to do as part of my current role. I'll just spend half a minute, but that's also actually bringing synergies across. And since he's actually part of the medical college, I thought I must talk about what we're trying to do in education and skilling. So something wonderful happened as part of NEP 2020, where of course Rajendra also was part of the committee who actually created NEP 2020, which also mentioned that we need to make skilling as part of education, the normal education, which actually has happened, and a lot of work has already happened. And what we're trying to do is to embed skilling everywhere in education, whether it's trying to do engineering or BA or whatever. So we're trying to we can actually have in a UGC program, suppose I'm doing BA of English, actually can have 50% courses, which could be skilling program. I could do, for example, a BA statistics with a minor in artificial intelligence and get a job somewhere wherever it's required. So that's already happened as on today, because some of these guidelines have happened. But why am I talking about it? Because I was going to medical college. Now, I think the medical, so somewhere in the normal UGC, AICT, all this has happened. So what we realized was there is a need for cross-sector skilling, because IT actually has become, or technology actually has become horizontal. It is no longer a vertical that we used to talk about it. It is embedded in healthcare. It is embedded whether you're trying to make EVs, you're trying to make drones, or you're trying to make any healthcare product, IT or EHR, or trying to even train doctors or MRI, it's actually embedded in it. So somewhere, I think, although it's already happened in the UGC and AICT, I'm sure it's going to happen very, very soon in the medical fraternity also, that somewhere some kind of skilling courses or cross-sectoral skilling actually, starts in medical college. Now, I have somebody who runs a medical college and nursing college here. So I thought we'll ask you as to what do you see as a change which will happen very, very soon in the healthcare teaching, both in nursing and in, for medical. What's your thoughts?
Thank you, ma'am, for that question. I think that's a very foresighted question that you posed, because as healthcare systems are evolving, more and more digital adoption is being done. We anticipate as a medical college as well that NMC will, or INC will, include more and more electives or even core courses on digital health, because our fresh graduates, whether it be nurses or technicians or doctors, none of them are being trained in a structured manner about the digital solutions out there, and that can be an impediment to things like Ayushman Bharat Digital Mission at the very least, and at the worst, it can lead to some serious health hazards, because if our doctors aren't trained to use digital tools properly, if they're not able to differentiate, if they over rely on something like chat GPT, and they're not able to differentiate how to use a tool and how to distinguish between something robust and something that is hallucinating, for example. So those kind of nuances need to be taught to our healthcare workers, and I think it's already high time that we start doing that. I'm hopeful that our councils will take heed of this and implement that. We've already actually approved a course on digital health with the Academy of Digital Health Sciences. So just last year, our academic council approved that as an elective for our medical and paramedical students. So I really hope that other universities also take the lead on that. Thank you.
What I think he just stated. So similar to that, recently also National Health Authority worked with the MUHS, the Maharashtra University of Health Sciences, and they had developed a course on what we refer it as DHFC, Digital Health Foundation course. And I think the Maharashtra University of Health Sciences is offering it as a white label course to be available to all the medical colleges. So that is also something which we had a partnership with, as NHA and MUHS partnered with this, and because it is wide label, so this will also be, I think, uploaded on CBC for larger dissemination. So this is, I just wanted to add.
I just thought, maybe a last point from everybody. Where do you see digital health moving in the next maybe 2 years? I actually will not even ask you for 5 years, because I think it's changing so fast. So what's your thought?
See, currently, if you actually look at it as a common man who is actually using health services, I generally go to use the digital health to actually confirm something which doctor has already said, or I'm trying to self-medicate, for some small ailment. So that's a current mindset which is there. But over a period of time, the kind of solutions which we discussed right now, and with AI coming in, I think it is going to be more pervasive. Currently, as part of my other hat, which is the director on India AI for AI coach and application development, we are inviting problem statement. We already have solutions in the 4 areas of health from the AI, which we are going to scale up. And also we are inviting more problem statements, which we will scale up over a period of time. So something which we have 4 problem statement, which we are talking in India AI system. We are talking a few problem statements which we are solving in Bhashini domain, and we are looking for more. So I think it's going to be pervasive over a period of time.
Yeah, yes, ma'am. In fact, I would like to answer this from the technology perspective. We have seen this software development, EHR, EMR, and then we have also witnessed the enterprise architecture. From there, now we are in this era of AI, ML, DL, leveraging images, data, and then delivering results, boosting diagnostic confidence of doctors. What I see is very soon, this entire AI will be, the classical AI will be taken over by quantum computing. And if you look at the in radiology particularly, I have seen research papers. In MRI, I have seen the how do I accelerate scanning, how do I reduce the imaging time with the help of quantum computing. So that is something which is coming very fast, and India is also taking lead in this with the help of National Quantum Mission. So that is something which I feel the way
Yeah.
forward is.
I just thought I'll talk about a case study, which I'm sure some of you may have read, which is when IBM Watson was getting implemented at Johns Hopkins University. So one of the things that they wrote a lot of rules, and this started actually almost maybe around 8 years back, 7-8 years back, and they've done actually a lot of good job there. But somewhere they did find the speed of the systems that time as because the rules were so many, which are there in a brain of a doctor. But for a computer, the rules were so many that it was taking time for processing. And that's why I think he's talking about that maybe the quantum computing concept that's coming in very, very soon, very, very soon, should be able to solve that large problem solving thing. And hopefully we'll have, especially in healthcare, this would be a aid. So what's your thoughts, Himanshu?
I'll not say much about what is going to happen, but I'll state what NHA will go to for next 2 years. So as I mentioned in my presentation as well, I think our focus is to create that data in the ecosystem on which I think we'll be able to do many things, which I think what Meeti and Bhashini has talked about. So our endeavor is to digitize at least 50% of those 600 crore record which are generated annually. So that will be our target.
Wonderful. Just to let you know, before I come to the medical college, so I keep adding something of what's happening in education. So since I was speaking about NEP, there's a wonderful initiative that's been taken. I don't know how many of you know something called Academic Bank of Credits. APARS, right? So Academic Bank of Credits is that anything that I do in part of my education or my skilling, any certificate that I do, the credits of that will go to ABC, which is Academic Bank of Credits. That's already implemented. In fact, most of the higher education institutes, I'm not talking about medical institutes yet, but most of the other higher IITs, ISCs, NITs, etc., even schools are already there on ABC. And it's going to give us actually a data which is going to be humongous and clean data. It's going to come from groups like CBSE. It's going to come from IITs directly. And they've actually done a wonderful thing in terms of creating an API, which actually helps all these engineering colleges and others to actually load the data. So we're going to have data which is clean data of what education background our students have. So tomorrow, if I'm looking for somebody with XYZ expertise, I'll actually have that in ABC. So if I'm looking across India that look who's done this kind of a course, I actually have the data in something called ABC. That's the kind of power that ABC is going to give us over a period of time, right? What is the kind of experience people have, certificate people have, what is somebody who knows Amazon Cloud or Microsoft Cloud, plus healthcare, plus whatever. So that's the kind of power the data is going to give us, which actually is already happening. The data is getting collected as I speak today, right? Which I'm sure will happen with medical college also. But I'm sure medical colleges also are going to go through a massive change. So your thought in terms of the next 2 years?
Right, ma'am. So specifically when it comes to medical colleges, I feel the assessment criteria of medical colleges would need to evolve eventually. We would have to move more towards the critical thinking, the analytical power of the students, rather than the memorization level of memorization that a student can do, because no human mind can compete with an AI that is connected to virtually all learning resources and is able to spit out everything, whereas we have a bottleneck when it comes to learning things or memorizing things. So no point in eventually I feel that we will reach that point where we realize that there's no point in assessing the memorization power of our students. Rather, we focus on the reasoning ability, the critical thinking aspects of things. So that's as far as the medical goes, education. And the other thing, that what was your original question, that how I see digital health evolving. So I see digital health making healthcare hyper personalized. So I'm sure most of you would be familiar with the concept of digital twin. So the more data we generate, and the more data we are able to collect about ourselves, and also make those data repositories which help build better systems, and of course ultimately uh, once we get that level of computational power, as ma'am and sir mentioned, so after that, we will be able to hyper personalize medicine and do justice to each of the patients. And that's something that we require for a long time, because there's so much data being generated, and data in terms of the literature. Medical literature is evolving quite fast, and it's not possible to keep pace with that. So we do need better processing power, and hopefully with these announcements by Google, by Microsoft in the past few months, I'm also hopeful that we'll be able to reach that stage.
Thank you so much. I think wonderful. Hyper personalization. And I think like our doctors really talk about evidence-based care. I think it's a combination that really comes in, which is going to be the future, even I think so. But I think I'm going to leave the last set of remarks to our dear friend, Rajinder. So you are an expert in this area.
Firstly, it's very heartening to see that, when you write a few lines, how they change into massive programs. At least today, when I hear Academic Bank of Credit, the NEP, when you were writing, there are a lot of skepticism in the minds of people. And we always used to say that, I always had the luxury of having very good ministers as my bosses who gave me the freedom. Like in health, when I wrote, a lot of people said, why you're creating NHA? There are so many things, ICMR, NHSRC. I said, these are all fiefdoms. They will not change. We have to create a new organization. And look at what they have done. So when I go abroad, I tell them with pride, can you ever do 760, 740 million ABBA ideas? And this is just, we're not even halfway mark. Then NEP, the things that they're changing, that making India future ready. But specific to digital health, I think I'm going to just tell you what we have done. So the Patients Union app is going to be your primary point of contact for getting information with regards to primary care. This is as we uploaded today in 16 languages. Of course, it is beta, so it is getting refined. We are partners with Bhashni, we are partners with the Indian Pharmacopoeia Commission, where you can do ADRs. But essentially, what we intend to do before the end of the year is, if in your area you don't have primary care physician, it will be your primary care physician. So this is what we will do. I'm not talking of 2 years from. 2 years from now, we will be able to do a lot more things. And this will always be free. There will be no charge you pay anytime. I think before the end of this year, we'll have our own LLM. We are working on that. And it doesn't even take $5 million, for which people get a lot of publicity in China. It's damn cheap as long as you know how you do it. So we are not there to create, hype, because we don't looking at building $1 billion. We want to make sure, because I have seen areas where people let their relatives die. You have seen the first discussion of patients, what they're passing through. So what we wanted to do through Patients Union is, if you do not have a doctor, you don't have to worry. You don't have to get into 4 walls. 5 fingers would be good enough, as long as you have a cell phone which is connected to the net. I think end of the year, we should be able to get you a primary care physician at zero cost.